Thank you. All right, so I'm going to go ahead and call this fifth work session to order on the alcohol tax. Let's go ahead and start with a roll call.
Yes, Mr. Chair. Miss Allard.
Here.
Mr. Constant.
Here.
Mr. Dunbar.
Here.
Miss Kennedy.
Here.
Miss LaFrance. Mr. Peterson.
Present.
Mr. Perez Verdia. Miss Quinn Davidson.
Here.
Mr. Rivera.
Present.
Mr. Weddleton. And Miss Zalatal.
Here.
Okay.
Thank you. As normal, if assembly members need to get in the queue, please either put yourself in the chat or text me if you can't access the chat. Okay, so we are here today to go through a series of questions that were raised at the September 11th work session. And we wanted to just go through the discussion, maybe not finish it up, but at least start the discussion on some of these items that were brought up. I will go through the list really quickly, and then that is it for this work session. That's the only intent. Like I said at the Rules Committee meeting, I will schedule any additional work sessions on the alcohol tax as needed, if needed, after the budget comes out next week. So the three questions that were asked by the members, and they wanted this time to explore those, were as followed. First, Assembly members wanted to know a little bit more about the cost and need of public defenders per the request put forward by the municipal prosecutor. Second, how do the mental health first responders and core team align? And then third, how will abatement, cleanup, and overnight shelter be incorporated into future budgets? So we'll go ahead and start with the first, and then if there are any other questions that folks think of while we have all of these folks here, we can go through any additional questions after we're done with these first three series of questions. So first, we'll go ahead and start with the question around the public defenders.
This is Sarah Stanley, municipal prosecutor. So we have a contract with Denali Law Group to provide indigent representation. And in that contract, it's actually built into it that as caseloads increase, the contract can be renegotiated. And in fact, that happened last year, where the case numbers went up. It was renegotiated for an additional about 120,000, between 100 and 120,000. So in our request, we're asking for one additional DV attorney and a DV secretary and some other resources. If the caseloads do go up, I think that the budget for the Indigent Defense Council is protected in the sense that if it goes up enough, those increases will be triggered, the contract will be renegotiated, and they will get more resources.
Thanks. Let me just go to my chat so I can see folks in the queue. Mr. Dunbar.
Thank you, Mr. Chair. Ms. Stanley, can you put a dollar amount on that?
Yes, the contract last year before the amendment to the contract was 1,028,000 and change. I might not have the exact dollar. Currently, it's now at now it's at 1,148,000 and change. So basically, to add another, and if it goes up, if it increases by 30%, the caseload, then that triggers the renegotiation. So roughly, to add another defense attorney would be about another $120,000, but that would happen when caseloads went up to 30%. Then it wouldn't automatically be another 120, but that's when it would be renegotiated.
Can I ask a follow-up to that, Mr. Chair?
Go ahead.
Do you anticipate the addition of the DV prosecutor would cause that kind of increase?
It might, or it might not. I can't say for sure that it would. I cannot say that it would definitely increase caseloads 30%. I mean, our resources is one factor, but another factor is just how many cases are referred to us and, come in the door. So.
Thank you, Mr. Chair.
Thank you. Ms. Quinn Davidson.
Thank you, Mr. Chair, and thanks for being with us, Sarah. So I'm not really sure I track your rationale. If the prosecutor's office needs another attorney, which I don't doubt, to manage its workload, even without taking on further workload, why wouldn't the public defenders need the same thing without taking on additional workload? So to me, it puts you in a position where suddenly your workload is reduced to work on the same cases that the PD's workload is not reduced on. Does that make sense?
Oh, yes, I understand your question. I think part of it is we could really improve our outreach to victims and are working with rehabilitative programs and tailoring plea agreements to be more custom designed for each defendant. And those things aren't things that the defense attorney, would be doing. I mean, talking to victims and taking their concerns into account and helping them to get resources, that's our job, not the defense attorney's job. Same thing with working with programs to figure out better rehabilitative plea agreements for people. That's on our end, not their end. So some of the things that we would like to have more resources to do better are things that are like squarely in our domain, not the defender's domain. Having said that, if the assembly, if the assembly wishes to go ahead and, sort of forward fund more money in case the contract is renegotiated, my office has no objection to that at all. But
thanks.
Yeah.
Yeah, I think as we are, I would be uncomfortable raising your budget to do the same work and not raising the work that you're doing and not raising the PD's budget. I mean, unfortunately, we have this sort of adversarial system, and I'm a lawyer, I'm part of it, I understand it, but to put one-sided an advantage to do the cases that you're both working on seems unfair to me. So I don't think I was initially supportive of doing this, but I don't know that I can be given that. Thank you.
Thank you. Mr. Weddleton?
Yeah, I apologize, everybody. I think I totally lost track of what's going on here. So, Ms. Stanley, you're a prosecutor and wanted more funds. Is that correct?
yes,
Okay. And that would be for another attorney and a secretary, right?
yes.
Okay. And then the implication of that is, well, now we need more defense attorneys. Are all of our public defenders the contractor?
Denali Law Group handles the vast majority of our cases. I don't know the exact percentage. But, yes.
But do we have a couple on staff, public defenders?
No, so no, they're all contracts. So we have a contract with Denali Law Group that handles, I'm guessing 80 to 90% of all our cases. Then we have a couple other contracts with people for conflict counsel if Denali Law Group has to conflict out.
Okay.
So we don't have any in-house public defense. It's all done through a contract with Denali Law Group.
Okay, thanks. That's very helpful. So, and I'm not sure. So is Austin's point then, if we're increasing you with another prosecutor, then we need to balance that. We must need more defenders. Is that right, Austin?
Yes.
Okay. Okay. Now caught up. Thanks.
Thanks, Mr. Weddleton. Any other questions for Ms. Stanley on this topic, or anyone else on this topic?
Yeah, Mr.
Okay.
Chair, I would.
Oh.
I would.
Go ahead.
Yeah, Ms. Stanley, what would your response be to the point made by Ms. Quinn Davidson? And is there a way to internally balance so that the increase doesn't unfairly kind of shift the balance?
Well, the contract with the Denali Law Group is governed by a contract that's actually negotiated by our civil department directly with Denali Law Group. And in the past, I actually haven't been privy to that. But I mean, if it's the will of this body to allocate more money, basically, we would have to renegotiate that contract to make that happen.
Thank you.
Yep.
All right, not seeing any further discussion on this one. We'll move on to the next question. Thanks so much for joining us. So next question, this one's a big one and complicated, but we'll try. So how do the mental health first responders, which I think is in its sort of an infancy stage, and the core team align? So I don't know who wants to start. Chief, it looks like you're ready. So if you want to go ahead, start, and then we will roll on through other folks who want to add into this subject.
Okay, good afternoon, everyone, and thank you for the opportunity to talk about this again. As I've mentioned multiple times, I'll talk about this to anyone and everyone to make sure that we are being clear. When the core team was initially developed, our hope was that we would actually add mental health providers to the core team, and with the purpose of being that mobile mental health outreach. So in our mind, the vision from the fire department was the work that we were pursuing. So the budget that we presented to fund the core team involved firefighter paramedics to deal with the often co-occurring medical situations that we see in these same customers, and the mental health piece. By bringing on a mental health provider, behavioral health provider. So that would be the team who actually would be in the field, in a suburban, respond to when we got these calls and evaluate and work with the individual, and backed up by a social worker. So our team is 3 people. It's a social worker, a behavioral health specialist, and a firefighter paramedic. So that's our entire kind of vision for this, was that we would be that mobile mental health piece, because it is quite often that the people that we're dealing with have co-occurring disorders, everything from medical situations that led to their mental health crisis, or a mental health crisis that has exacerbated or turned into a medical problem, and a resourcing problem, which is where the social worker kind of fits in. So that was kind of our process, or our thought process for even developing the core team. And knowing that quite often these are also had the substance abuse or substance misuse side of things as well. So that's where we got the concept for the core team.
Thanks. And I think we'll have 2 additional comments that I think will help frame this discussion. And then if I know I also have the Chief Dahl here who might want to add in, as well as Heather Harris, the director of the Anchorage Health Department. So first I'll turn to Ms. Zalatel, then Ms. Quinn Davidson to hopefully help frame this a little bit more, and then we can get to the meat of it. So go ahead.
Thank you, Mr. Chair. So a few questions for Chief Hetrick. And first, thank you for your invitation to do the deep dive with members. I really appreciate that. So I won't go too deep on the dive right now, but I do have a few questions just to remind me of a few things. One was the budget request, not just this year, but in the succeeding years. I remember it went up quite a bit over a period of time. So a reminder on that would be great. And how that fits with putting on a team, expanded core, that would it be 24/7 response to those behavioral health, wellness, whatever that categorization of calls are, that it would be diverted. Is that what's contemplated in the budget request for 2021 with alcohol tax, or is that a longer term build out in your requests? Thank you.
Thank you, Assemblymember Zalatel, through the chair. Our original proposals, we wanted to set up the team, and the original cost was 1.7. That was 12-hour teams, 7 days a week. So basically, we would have each team would be offset. So we would have a team available 12 hours a day, 7 days a week for response. And we also ask for an admin person because of the paperwork that would go with this type of a program, an additional dispatcher because we anticipated increased call volume at dispatch that could route these particular types of calls, and then a management position. So that was 1.7. And then we had proposed in sometime in 22 that we would add a 2 other teams. So that pushed the price up to about 2.8. So it was hiring 1 team, or 2 teams to start the 12-hour a day team staffing. And then in the next year, if the need was relevant to, or if we weren't solving this problem as effectively or the volume increased, we included a budget projection if we added teams so that we could be 24/7.
May I ask a quick follow-up, Mr. Chair?
Go ahead.
Was the 2.8 million in 2022 an additional 2.8 or a total of 2.8 by that point?
That would be a total of 2.8.
Okay. Thank you for that clarification. I appreciate it. And then the other follow-up I have is there a defined type of call that you're contemplating with CORE in doing this type of work? I know we're going to have Chief Dahl talk as well, and I'm just kind of trying to get a sense of the scope of the work.
When we originally focused on, when we were originally building out the CORE team, we developed kind of a framework of which type of calls these would be. If someone calls 911 and they have through our triage system, we identify that they have definitely a medical need, then we would still continue to send an ambulance and fire engine and get them the resources that they need. These would be the calls where that maybe an individual has called 911 3 times or maybe 2 times in the last 24, 48 hours, and it's an indication that they're going into crisis. Then the response team would, or the CORE team would actually respond to them and find out what else is going on with them that's causing them to be a user of 911. The whole purpose was to really focus on those people who don't self-identify, which is a significant amount of our people. It's someone else calls for them, or they're calling 911 because they don't know what other resource to call. So our dispatchers would help triage that out and then identify, yes, if they need medical, then we immediately send an ambulance. But if they don't need medical, then that was the fill-in for the CORE team. And that's kind of been our experience, that those people who really shouldn't be transported to the emergency room are the ones that we are hoping to address with the CORE team.
Thank you. All right, so next I'm going to turn it over to Ms. Quinn Davidson. Then after that, I want to see if either Chief Dahl or Ms. Harris have anything they want to add before we go back in the queue. So go ahead, Ms. Quinn Davidson.
Thanks, Mr. Chair, and thanks to the Chief for that description. This may be obvious to members, so apologies if it is, but it wasn't completely to me, and that's why I reached out to the Chief, and we met yesterday, or was it just yesterday these days, to just talk about her proposal she had made. And then also, there've been sort of these 2 simultaneous suggestions we've had in alcohol tax discussions. One is the CORE team proposal, and then one is a mental health first response, sort of more general proposal for $2.5 million a year that it would take to operate it. As you know, Meg, I think she led that charge, and we approved hiring a consultant. So that consultant is going to be working with Meg and with the Chief, who's going to join in a conversation to find out where there's overlap with those programs. So we're all trying to do the same thing. It's just trying to figure out how we'll do it. And at the same time, I alluded to this in the last meeting, but Bill Falsey and Mental Health Trust and a bunch of other folks have been working, Agnew Beck as a consultant, experts in the field have been working on trying to develop what would a comprehensive mental health response system look like in Anchorage? And of course, we talked about this during the CARES Act funding as well, because it would take that $3 million we appropriated of startup funds. So anyway, it's all connected, and we're just trying to figure out how we can all work together to do the best possible response system. And that is why the chief is here, and that's what the consultant's doing, and that's what everyone's kind of, but it seems a little confusing. Sometimes they seem really disparate. So I just wanted to clear that up.
Thank you. All right, so next I'll turn it over to Chief Dahl if you wanted to add anything to this discussion.
Thank you, Mr. Chair. I appreciate that. Actually, I think Ms. Quinn Davidson gave a really good summary and largely hit on some of the things I was going to say. That's kind of where APD sees this. There are sort of multiple different components underway right now. I think they're all trying to head in the same direction ultimately. The police department has the mobile intervention team, and the mobile intervention team right now is filling the gap, right? We know that we don't have really any sort of mental health first responder type setup in Anchorage. And so the mobile intervention team focuses on mental and behavioral health conditions that are running into contact with the police department on a regular basis. They're not really a case management per se, but rather refer people to community mental health providers and then make sure they're connected appropriately, stuff like that. The mobile intervention team doesn't limit the number of people they're working with to a specific number. It's more based on the severity and nature of the calls that those clients are generating with the police department. And then they also work with patrol officers in the patrol division to create response plans for people that are frequent callers to APD. But I think in our long-term vision at APD is to essentially get out of that business altogether and have professional mental health providers. And I think that if you look at the Crisis Now model, or like I think Ms. Salatel brought up the Cahoots model from Eugene or Salem, I think that was from Salem. Anyway, those are typically NGOs that provide that service, and we think that's a pretty good option. But we definitely think that not having police officers respond to those things is the right direction to go. And I'm actually going to turn it over to Deputy Chief McCoy a little bit, because he's sort of our in-house subject matter expert and has seen some of these things firsthand. DC, if you want to add to that.
Thanks, Chief, and good afternoon, everyone. I'll be brief. I've spoken to several of you about Crisis Now and our vision and desire to work with that program and see it fully functional here in Anchorage with a crisis call center, mobile intervention teams that are available 24/7, and a true stabilization center. So again, we are fully supportive of that and are working very hard to keep that momentum going. And for many years, there's been a gap in the system, and that's where our mobile intervention team came to be to help fill that void for us. And that team consists of a patrol officer and a social worker whose primary mission is to go out, make contact with people who are experiencing mental and behavioral health issues, and connect them with resources. With us only having one team, we have to prioritize and just focus on the most severe cases and our high utilizers. And it's been an effective program. However, we think we would be better served by having professionals in that field available 24/7 to address those calls in the community. One thing the chief did mention that we've done recently with our mobile intervention team is create patrol response plans that are designed specifically to address individuals. These plans are provided to our patrol officers, so if they have to respond to one of these situations, they have a good idea of different triggers or calming mechanisms that they can utilize to work with individuals involved. So again, our MIT team has been a good stopgap for addressing the problem. Obviously, there's not enough coverage for us to adequately impact the entire community need. And we would hope that we can come up with a comprehensive system for all of Anchorage. And again, that's our focus, and our primary goal is to assist seeing that come to completion.
Great, thank you so much. Last person I wanted to invite to add anything else if they wanted was Heather Harris, and then we'll go into the queue.
Thank you, Mr. Chair. I would just like to echo the conversation that's happening here and just the interest in providing a comprehensive service to our residents here in Anchorage, and just the great work that's happening there at the fire department around this issue specifically right now, and appreciate that they have infrastructure that could be built out or supported and increased in the future. Here at the Anchorage Health Department, we are not in a place that we provide behavioral health services. And while we're supportive of this philosophically, that just really highlights the difficulty that programmatically we just don't have the infrastructure or staffing at this point to engage in providing services of that nature. And so happy to be part of the overall conversation and making sure that something is moving forward and providing thoughts about that as we move forward. So thank you.
Great, thank you. All right, so I'm going to go ahead and start going through the queue. First, I have Mr. Weddleton.
All right, thanks. I guess you've heard it before. It just knocks me out of my chair when I see the expense of doing this core team through the fire department. And I think it seems to me the organizational structure at the fire department is perfect for crisis things like fires and so on, but something that is kind of this nature, it's just unbelievably expensive. And, it's like, and it's kind of at the health department, Ms. Harris said that they don't have the infrastructure, but in a way, the fire department does not either. I mean, what they've been doing is they have one person doing it, and he's taken off a rig and he is replaced with people working on overtime. So one person working is $250,000, and it's been very successful, but that's just, that's a lot of money. And if that same money went to the health department, I believe it would be cheaper. And so I'd look for perhaps something run by the health department that called on a firefighter when needed, and I think we get a lot more done much cheaper. And then Ms. Harris, you would have the infrastructure. 2.8 million, you could do something with that. So questions I have also from Ms. Hetrick's, my understanding of this whole core team thing is, that you go to your frequent callers and you kind of work with them so that they don't frequent call anymore. So I'm curious how another dispatcher would be needed for increased call volume, because I thought the whole, not necessarily the goal is to help people, but kind of ultimately it would decrease your call volume. Did I miss something there?
Assemblymember Weddleton, through the chair. Our initial hope is, or our long-term hope is, yes, that it would reduce our response volume. However, we think that for the first couple of years, once people find out that this is an option, we expect to have an increased volume for the response team. And because we know that we'll be taking care of more people than we are now. And that was the whole purpose of, yes, we started with one single individual who's able to focus on high utilizers because we had one person. But if we actually have a team who's making an impact in reducing call volume, then long-term, that's what we would hope to see, as a reduction in the calls, because our community would be safer. And I would like to touch a little bit on the expense. We do have the infrastructure to do that. That's exactly what we do, because it's not just the personnel, it's the managing the data, the biometric system we're using to identify high risk or people who are going into crisis. all of that is incorporated in our current system, so it is a cost that wouldn't have to be expended. And one of my concerns that I've seen from the Agnew-Beck presentation that we saw a couple of weeks ago was what they are considering pay for mental health, behavioral health workers. It is a very well-known fact and was even stated by Agnew-Beck that mental health providers and professionals are extremely low-paying positions. So you don't get, you don't get high-quality people who want to go into that business because they can't feed their family and they can't support their family in that kind of a career field. You get people who work for lower pay. Yes, they have a passion about that and would like to do the work. However, they don't stay. That's been our experience. And high quality people that can go to work stateside, maybe in Maricopa County, to do the same kind of work are going to get compensated better. It costs more to live here, and there has to be some type of incentive to stay and do the work. So that's one of my biggest concerns is if we under budget for the cost or for the value of the people who really need to do this work, retraining and the constant turnover is a significant problem for the population we're wanting to serve because they need to build long-term relationships with this clientele.
Great, thank you.
Thank you. Mr. Dunbar.
Thank you, Mr. Chair, and I appreciate this conversation. I think it's helped bring to the surface some issues and some things we're going to have to discuss and to clarify. I appreciate the chief's presentation. I think it sort of highlights the ways in which the core team is actually different from mental health first responders and different from a crisis now model. And I think to what John was saying, you know, there are three portions of this. There's the 23-hour center, there's sort of where you take them, there's the teams, and then there's the dispatchers. And dispatchers have to be specially trained and they have to be able to differentiate, you know, when is the right time to send a police officer because we think this person is violent, or a paramedic because we think they need to be taken to the emergency room, or they're having a real, you know, that kind of physical health crisis, or a mental health first responder. Because what John was saying is absolutely right. If you are having a paramedic and a behavioral health specialist, which we want to pay well, go to every call, it is going to be much more expensive. And it's also the case that in crisis now and those kind of systems that have worked elsewhere, they have a peer that goes with the behavioral health professional. You have someone who is from that community who is like an assistant and can relate to them. And so I guess I want to ask Chief Hetrick, are you planning to have that peer go out with your core team?
Assemblymember Dunbar, through the chair, that's actually one of the proposals we're looking at. We recently applied for a grant through the state of Alaska to for funding to add a substance abuse or substance misuse specialist with kind of working with the core team, and we're working in partnership with Providence Hospital on that program, and that did include some peer workers. Just at this point, we don't have a lot of those people available in Anchorage. So I think that is definitely an area that we would like to expand to, because we agree that is a place that might be a better, or an individual or a position that might be a better fit in many cases.
Right. I mean, so we dedicated $3 million of CARES Act money, which might now be converted into a way that can be spent after December if we can't get it fully stood up by then, to do that kind of, I hope, initial training. That, you know, there'll be some infrastructure purchase, but there also will be the training and recruitment of peers and of behavioral health professionals. And then going forward, you know, we'll have that, whether it's $2 million or $2.5 million or whatever the amount of alcohol tax ends up being for the ongoing costs. I think what we all agree on is this is not going to be able to happen. You know, we're not going to be able to flip a light switch and have this happen. It's going to take a while to build up the capacity and to have this going long term. But I want people to hold the two things separately in their mind. The core team does a different set of things than what the Crisis Now mental health first responders do in places like Maricopa County and in Eugene, Oregon, and places like that. And they're structured differently too. And I am worried about this idea of like the core team sort of subsuming the mental health first responders as opposed to working beside them, because the way you described it, they're going to people who are frequent utilizers and who and doing the good work the core team is doing. But that is different than people who might be having a first-time crisis and calling, the hotline or the dispatch center for the first time. And it's also the case. I mean, I was a little puzzled too. One of the things you said, Chief, was talking about how the core team, if expanded, would go to people who don't need to go to the emergency room. And so I guess my question is, if they don't need to go to the emergency room, why are we sending a paramedic?
Assemblymember Dunbar, through the chair, that comes down to the co-occurring situations that we've seen. Often people who are in mental health crisis have other co-occurring orders, and it could be a substance abuse issue. It could be they have a medical situation going on that has exacerbated their mental health crisis. So for example, firefighter Riley, who works with us, often people don't need to be transported, but we have a system to where it triggers that this person is called 911 and on multiple times. And that is just an indicator that they are going into crisis. So he will actually go to that person, whether they're in a camp, on a street corner, when they're in the ER, if they're a patient that we're already tracking, and have a conversation about exactly what's going on. We recently just, actually I think it starts next week, we have a graduate student who will be mental health professional, graduate student, who will be traveling with him, because that's what we need, is we need both often medical care and mental health care at the same time. There's and I cannot give you the number now of what that percentage is, but it seems to be a very common occurrence. And these are, as I mentioned before, these are people who cannot self-identify that they're going into crisis. So that's why we have implemented this system called First Watch that actually can help us identify that those people are going into crisis because they can't recognize that for themselves. And yes, right now we're focusing on high utilizers because we only had one person and we had to start somewhere. And as Chief McCoy mentioned, we got to go where the need is greatest. But that was not the original plan for the core team. It was just to use their usage of 911 as an indication that they were going into crisis. Did I answer everything there?
Yeah, I think so. And I know we are meeting next week, a couple of us. I know you're trying to meet with everyone more individually. I do think that there is going to be decision we're going to have to make in the next few months about, and the consultant I'm sure will help us make this decision about which of these paths we sort of go down. I think my personal feeling now is that expanding the core team and sort of subsuming mental health first responders into the core team is a very expensive way to do things, and it doesn't really get to the sort of system that we've seen work in other places with Crisis Now. On the other hand, I definitely see a role for the core team as working side by side with the mental health first responders, and then perhaps that also will reduce the need or even the existence of APD's version of this, the MIT. But I think they all do slightly different things, and I just hope that, and I understand Ms. Harris's point too, that the health department is small, they are very much stressed by COVID-19, and they can't turn this on quickly either. But I still feel that if the resources are dedicated, that the health department is a more appropriate place for something like Crisis Now than either the fire department or the police department. Thank you.
Thank you. Just checking in, Deputy Chief McCoy, were you going to answer one of Mr. Dunbar's questions?
Yes, I just had a small follow-up, and that's basically, I think we are undervaluing the call center in the Crisis Now model. The call center in the model is staffed by clinicians, and when those calls come in, those clinicians are able to stabilize and resolve the issue 80% of the time and get the person connected with resources. In the situations where they're not able to, they dispatch a mobile team. So the call center is, I think, a very valuable piece in this whole continuum that I don't think either our dispatch center or the fire department's dispatch center can operate at that level. So it's just something I want to throw out for consideration. Thank you.
Thank you. Ms. Zalata?
Thank you, Mr. Chair. I appreciate the comment by Deputy Chief McCoy, but I think I like to keep drawing us back to the focus and intent, which was to work on this middle piece of the first responders, knowing that the call center and the crisis stabilization centers, kind of piece 1 and 3, are in the works, maybe on a larger statewide level. But my question is for Deputy Chief McCoy and the chief, which is the call type that APD would like to see, diverted to another agency or response similar or different than that of what CORE is envisioning, or even what do they envision in terms of crisis now? What are you envisioning will help alleviate the workload and there would be a more appropriate response that is not APD? Because I think we're talking about different call types. So I'm just trying to get a sense of what your vision is.
So this is DC McCoy. So I think the difference at the base level is that the calls that we typically get involving someone in mental or behavioral health crisis don't have the medical component to it. And so we're responding to those situations and trying to resolve them with patrol officers. And I'm sure Chief Hetrick can speak to this, but the core team, and there's a medical component to those calls. And I think that's where we diverge. And so there are times when both teams work together, when we identify high utilizers who are using our resources and are heavily reliant on medical responses, and then our teams work together jointly to come up with plans and do a co-response to deal with those. But I think that's the defining line, that medical issues aren't in our purview.
Mr. Chair, may I ask a brief follow-up?
Go ahead.
Thanks. I appreciate that, Deputy Chief. Is there a categorization of calls that APD currently deals with? I don't know, wellness check or something like that, that you could envision would kind of peel off your initial response and be subject to a different type of response?
Right. So oftentimes we get calls. It may be a disturbance or an assault. And we get there, and as we sort through it, the root cause of the problem is a behavioral or mental health issue. And then, and that's how we have to try to resolve those problems. And that's where we're often left with, no adequate resources or no place where we can take the individual where there's not an actual criminal offense in play. And so, yes, we get calls, welfare checks, to check on individuals who are experiencing mental crisis. But again, a lot of times the calls we respond to have an underlying mental health issue, but it's not defined as that up front. And normally that comes after we get on scene and start sorting things out. And the person that vandalized a local business, there's a behavioral health issue involved there that resources could be brought to bear to assist with.
Thank you.
Thanks. All right, so I'm going to go to Mr. Constant, then I'm going to move us on so that we can answer the third question of the ones that were brought forward, and then we'll open it up to see if there are any other questions. So, Mr. Constant. Mr. Constant.
Sorry. So a couple of things, hopefully briefly. I missed out on the topic of hiring a consultant. Who did we hire and what's their scope of work is my first question. And second is, when we talk about AFD being an expensive team, so is APD. These are really our two biggest budget items across the board. And so it's important to be analogous in that sense, that one isn't really more expensive than the other. I think the health department is the value meal, as Mr. Welleton pointed out. I just don't know how that intersects and plays in terms of the formal procedures, but we'll determine that once, I guess, we make a call on which path we're going forward. So, but really my question is, who is this consultant and what are they doing?
Ms. Zalatel, do you want to address that?
Sure. So the consultant is one that we had, through an amendment on the CARES Act funding, put forward of $49,000, I believe. And they're doing a lot like what the port consultant did, looking at the menu of options for mental health first responders and evaluating both the Crisis Now model and its potential implementation, the core and where that overlap might be, as well as other models around the country, and then also evaluating a couple of things. One, workforce capacity, which is an ongoing issue in Alaska around behavioral health, and then 1115 waiver billing, I guess, or what services could be incorporated so that we can consider the fiscal longevity and funding of the program.
I remember now. Thank you.
In a nutshell. Thanks.
It's Colston. Thank you.
Thanks. And I think at some point I've spoken to Ms. Zalatel about having a work session with the consultants. I think that's probably, we're thinking maybe in October or future. So that'll be happening soon. Okay, so I'm going to move us on to the next topic, which is how will abatement, cleanup, and overnight shelter be incorporated into future budgets? I am not seeing the individual I had invited to answer this question. So would someone from the administration want to address this question?
I'll take a shot at it, Mr. Chair. This is Jason Bockenstedt. I think to the extent that a number of those items have been on the list of items that would be funded with the alcohol tax revenue, I think we're taking a good hard long look at that, at the documents that have been shared with the administration from the Assembly's perspective that I believe include most of those items. We're taking a hard look at that to see how we could potentially incorporate it into that. But if not, I think we all agree that these are specific items that the community has, I think, very loudly said that they would want to see. So we're working very hard to incorporate year-round camp abatement and some of the other items that you mentioned into the budget.
Thanks. Before I get to you, Ms. Zalatel, I just want to note, so it looks like the consultant that was discussed in the previous question is going to be joining the Health Policy Committee on October 7th. So that'll be your opportunity to talk with the consultant. Ms. Zalatel?
Thanks. Two quick things. Again, I will invite, if you have questions you would like me to send to the consultant ahead of time so she can be ready for them at the Health Policy Committee meeting, please do so. And the question statement I want to make with regard to what Mr. Bockenstedt said is basically the potential budgets that have been put forward. The one from Health Policy and the Committee on Homelessness really made a presumption that we would try to find these dollars in general operating dollars versus the alcohol tax. And if that's not possible, and we really do have to look at the alcohol tax for those two particular items, it'll shake things up, I guess, because it was about $1.2 million, if I'm remembering correctly. So I just want to highlight that. And yeah, I'll just leave it at that. But I just wanted to highlight that that had been a presumption made in that particular proposal put forward by those committees.
Thank you. Okay, not hearing anything else on that topic. We'll go ahead and move to any other questions that weren't raised already. And I think I have one from Ms. Quinn Davidson.
Thank you, Mr. Chair. Can you hear me okay?
You're a little soft.
Weird. I am kind of yelling into my computer. Okay.
Now I can hear you better. Yeah.
Great. So I just wanted to, while we have Ms. Harris here, and I think Ms. Hall is also here, I had felt a little confused about some of the theory of change proposals and how those would incorporate into the work that we either are doing, will be doing with the equity position, could be doing through other avenues, and have been trying to work with Ms. LaFrance and with those two to better understand it. I think that Ms. Harris has potentially some ideas about training and procurement processes where we could incorporate some of the theory of change bigger picture items into the work we do at the health department. Would it be okay to have her speak to that? And potentially Tiffany as well?
Sure.
Thank you, through the chair, for the opportunity to speak on this for a moment. As we look at how to move forward in thinking about equity and how the health department and the municipality overall really engages with this topic, it's at the health department, we are thinking and talking a lot about how racism is a social determinant of health that drives health inequities nationwide and specifically here in Alaska. People of color are experiencing lower quality healthcare and poorer access to education and greater levels of prejudice than their white counterparts. And so as we think about health determinants and how we best align and evaluate our systems overall here at the health department and in the municipality, we think it's incredibly important to have training and support and dedicated staff to help move this interest in this idea forward and figuring out how we adjust our systems and structures. And I know there is some work around a chief equity officer on the administrative side, and looking forward to partnering in that way too. And so just as we move forward in this conversation around alcohol tax and around the budget, I do believe it's an important piece to have in the forefront of our mind about how we evaluate the systems and structures that we're engaging with our community and ensuring that it's equitable for our citizens.
And who else did you want to respond, Ms. Quinn Davidson?
Well, I know Ms. Hall had sent us some a short version of her document, a new document. And I just wondered, you know, she and I had some conversations about potentially training. That's something that Ms. Pineda was supportive of too. And so if she wanted to speak to that quickly, I think that'd be helpful for the members.
Go ahead, Ms. Hall.
Hi there. Thanks so much for the question, to the chair. I guess I would say just that our group loves the idea of putting any amount of funding really toward training. And I know that Ms. Pineda as well as Ms. Harris now at the health department have talked about needs for their staff to look at it. And I don't presume to know what the biggest needs are for them, but just to say that our group would fully support giving the health department some funding to think about health equity and how to address some of these social determinants of health and race-based disparities that we see. And we would be happy to kind of help try to do some research around what that looks like, if it's if the best options are not known, but there was some funding or capacity to do that. And then the other thought is also around just how the money is given out and whether it's given out through other organizations, through grants, or through the health department, through procurement. I guess we would just really love to see additional funding go to things like making sure that the that the review committee who makes those decisions includes people with lived experience and includes people of color, and that more efforts are made to do outreach to organizations that maybe aren't always in the know about government funding, because sometimes that does feel like a barrier. And I know that those things take time, but luckily the alcohol tax revenue doesn't all come on day one. And so I think there is some time to use some funding at the beginning to set up those systems and look at those systems so that when it is time to start giving out grants, once enough has been collected through the tax, maybe those systems can be in place. Thank you.
Thank you. Anything else, Ms. Quinn-Davidson?
I guess briefly, I would just ask Ms. Harris, as she's coming on board and keeping in mind our timeline, to really do a deep dive into those procurement processes and also potential training opportunities. And I've also asked her to be exploring the Chief Equity Officer and what that person's role is and how this work would supplement and accentuate but not duplicate. So, we need to be really careful and efficient with the alcohol tax dollars. But if there's a way to incorporate the community's comments and all this work that's been done into things that would be really useful and practical, I'd really like to hear about that in the coming weeks from Ms. Harris.
I'm happy to continue that conversation and just learn and grow together. And like it said, Ms. Pineda had great support for this and has led our team in this conversation. And I've been able to kind of pick that up and keep that moving forward. And so it continues to be a great interest of myself and our department overall, and making sure that we can use this as an opportunity to really evaluate and make a better process going forward. Thank you.
Great, thank you so much. Mr. Rivera has stepped away. I don't see any other questions in the queue. And is it true that we have 1 minute left? Yes. Are there anybody else before we go to members of the public? Okay, are there any members of the public that wish to speak in the minute we have remaining?
Hello?
Is that Mr. Haberman? Mr. Haberman, go ahead.
Yeah,
You have 1 minute.
I thought this was a work session. You don't have places for the public.
Okay, well, it's just turned 2:10, so maybe we're in agreement on that one. And I'll look forward to seeing you or hearing from folks in the next work session.
Thank you. Just note this: you need to put the documents on the website so we can follow you, because it's not happening. A lot of documents from today's meetings are not there. You're seeing it now, and the public's not seeing it. Bye.
Thank you, Mr. Haberman. Can I get a motion to adjourn?
Austin, can I real quickly?
Sure.
Can I move to extend by 3 minutes?
Sure. We have another meeting, but it's not until 2:20, correct?
Yeah.
Yeah. Go ahead. Go ahead, Mr. Dunbar.
Okay. Okay. Thank you. So there's someone else. They've been texting me. I think they want to speak, but they didn't realize. And that's Sean Sullivan. He wanted to make a comment about the his program vis-a-vis the alcohol tax. If that would be okay.
Sure, go ahead.
Hello, can you guys hear me?
Yes, we can.
Okay. Yeah, I just want to congratulate you on the work you guys are doing, and I don't want to really be too forceful, but I just want to say that you guys have invested in some outreach, and I want you to know that your money has been well spent, and we have been effectively out here since the time this grant has started. We've reached over thousands and thousands of people, housed multiple and dozens of people. So I really don't want street outreach to be overlooked, because this is a very, very, very vital key component of what it's going to take in order for these programs to be successful when it gets into the purchase of the properties and the treatment. These guys out here, the homeless population, they're really excited. I'm telling them about you guys every day. And I just hope that I can keep my word to them that we're going to be bringing something really special to the table for these guys out there. So I don't want to elaborate too much on my program. That is something definitely I'm going to be working with you guys, primarily, and we're going to work on it slowly and for surely. But I just want to say that the outreach key component of this is very strong, and we really appreciate you guys. So it's very effective out here. We're really making a difference with this outreach. So I want you to just know it's really working, and I want to move forward and try to broaden the perspective of what we can do and what we have to offer.
Thank you, Mr. Sullivan. I appreciate that. Since we've opened up to Mr. Sullivan, I want to give other members of the public an opportunity to talk. We have although we've now extended our time. Did you move to extend 5 minutes, Mr. Dunbar?
It's actually 3 minutes, so we have like 60 seconds.
Okay, we have 1 minute left. Anybody else? If not, I'll ask for a motion to adjourn.
Move to adjourn.
Thank you, Mr. Peterson. See you all in a few minutes.
Thank you.